Welcome back to the Deep Dive. Today we're tackling a really big one. The entire pharmacology unit focused on the central nervous system. This is the body's command center, running everything from breathing to feeling.
It really is. And trying to find the right chemical key to unlock treatments for things like pain or seizures or even mental health conditions,
Yeah,
well, it's incredibly complex. The stakes are just so high.
they absolutely are.
And if you look across this whole unit, the central idea really is balance. It's this constant dance between things that excite the nervous system and things that inhibit it. Neurotransmitters like dopamine and serotonin pushing one way, GABA pushing the other.
So understanding these drugs is basically about understanding how to tweak that balance.
Exactly. Whether it's a sedative for sleep or an antipsychotic, we're trying to fine-tune that neurochemistry, mastering CNS pharmacology. It's really about mastering that balance.
That's a great way to frame it. So instead of just chapters in a book, think of it as a toolkit for addressing imbalance. For you listening, our mission today isn't just listing drug names. We want to pull it all together. Show how managing pain connects to controlling seizures, connects to stabilizing mood. We'll hit the major drug classes, how they work, those really critical safety points you cannot miss, and, of course, how the nursing process ties it all together. Okay, let's dive in with pain management. That's often the starting point for patients, isn't it? Clinically, we first need to know what kind of pain we're dealing with.
Yeah, that's step one. Is it acute pain, short-term, like after surgery or an injury? Or is it chronic pain?
And the definition of chronic pain catches people sometimes. It's not just pain that lasts forever.
No, technically it's pain that sticks around or keeps coming back for longer than, say, 3 to 6 months, or even just a month after an injury should have healed. That persistence is key.
Before we even talk drugs, we need to understand how pain signals actually work. That journey.
Nociception, right.
Nociception,
Yeah.
exactly. It's a four-part process, basically. First, transduction. That's where the injury happens, tissues release chemicals, and nerve endings get triggered.
Okay, step one, activation. Step two, transmission. That pain message zips from the site, up the spinal cord, heading towards the brain.
Step 3.
Perception. This is subjective. It's when you actually feel the pain up in the cerebral cortex. Modulation. The brain doesn't just sit there. It sends signals back down trying to fiddle with the message, maybe block it, maybe unfortunately amplify it.
Which leads perfectly to the gate control theory. I love that analogy. Where is this gate? How do drugs shut it?
Think of the gate in the dorsal horn of your spinal cord. If enough pain signals arrive, the gate swings open, message goes up to the brain. Now, some drugs, like NSAIDs, work early on at transduction, reducing those inflammatory chemicals, like turning down the volume at the source.
Okay.
But opioids, they work more on transmission and modulation. They basically slam that gate shut. Much more powerful effect on blocking the signal travel.
Let's talk opioids then, the heavy hitters. These are synthetic drugs mimicking our natural opiate system, binding to mu-kappa, delta receptors. How do we categorize them?
Broadly, you've got your mild agonists, think codeine, hydrocodone. Then the strong agonists, morphine is the classic prototype here, but also things like fentanyl, hydromorphone, methadone, and the potency differences between these. Huge, really critical to know.
And then there's that trickier group, the agonist-antagonists, like pentazocine or nalbuphine. Why tricky?
Well, first, they have a ceiling effect for pain relief. More drug doesn't mean more relief after a certain point, but the real danger is their dual action. If you give one of these to someone physically dependent on a full agonist, like morphine,
Bad news.
very bad news. Because they also block receptors, they'll kick the full agonist off and trigger immediate severe withdrawal. It's incredibly distressing for the patient, so never use them together in that situation.
Okay, this is where we absolutely have to hammer home the safety priorities.
Yeah.
For anyone looking after a patient on opioids, what's the number one absolute critical risk?
CNS depression leading to respiratory depression. That's how people die from overdose. It's crucial for nurses to grasp this. Even if someone's on long-term opioids and seems tolerant to the sleepiness.
They still need careful monitoring.
Absolutely. Especially if the dose goes up or if they're getting other CNS depressants too, the risk is always there.
And if respiratory depression does happen, what's the antidote?
Naloxone, Narcan. It's a pure opioid antagonist. Works fast to reverse the effects. But here's the catch. The detail people sometimes miss.
What's that?
Naloxone wears off relatively quickly. Its half-life is much shorter than many opioids, especially long-acting ones. So you might reverse the overdose, patient wakes up, but an hour later the naloxone's gone, the long-acting opioid is still there, and they can slip back into respiratory depression.
So you need to keep monitoring and potentially redose.
Exactly. Vigilance after giving naloxone is just as important, especially with long-acting formulations.
We also have specific rules for things like the fentanyl patch. What's the key message there?
Okay, two big things. One, fentanyl patches are only for chronic pain in patients who are already opioid tolerant. Never start one on someone opioid naive. The dose is way too high. It's incredibly dangerous.
And the second thing?
Never, ever apply heat over the patch. No heating pads, no electric blankets, not even a super hot bath right over it.
Why is heat so dangerous?
Heat increases blood flow to the skin under the patch. This dramatically speeds up how fast the fentanyl gets absorbed from the patch's reservoir. You can essentially cause a massive uncontrolled overdose just by applying heat. It's a life-threatening mistake.
Well, okay. And another potency issue, the difference between morphine and hydromorphone, Dilaudid.
Yes, huge potential for error here. Hydromorphone is roughly 7 times more potent than morphine. Milligram for milligram, it's much stronger.
So a small dose numerically might still be a very powerful dose pharmacologically.
Precisely. Because the doses look small on paper, like 1 or 2 milligrams, someone might mistakenly think it's weak. You need meticulous checking and real awareness of that potency difference.
Beyond opioids, we use adjuvants, right? Like NS, acetaminophen.
Yep, helping hands. Acetaminophen, though, common as it is, carries that big risk of liver damage, hepatic necrosis, with overdoses.
And the antidote for that.
Acetylcysteine. It protects the liver. The IV form is easier, but the oral one famously smells like rotten eggs. Horrible stuff.
But it works.
Oh, yeah. Very effective, especially if you get it in within about 10 hours of the overdose. Saves livers.
So pulling this pain section together from a nursing perspective, managing that persistent chronic pain, what's the strategy?
It's about staying ahead of the pain. For chronic pain, the best practice is usually around-the-clock dosing on a fixed schedule, not waiting for the patient to be in agony and ask for it, PRN.
Why is scheduled dosing better?
It keeps the drug levels in the blood steady, prevents those dips where the pain breaks through, and avoids the peaks that might cause more side effects. It's about smooth control. And always, always assess, check liver, kidney function, because that's how these drugs get cleared. Hashtag 1.2 anesthesia bridge.
Okay, brief detour into anesthesia, building on this. Local anesthetics, like what you get at the dentist.
Right, things like lidocaine. They block nerve signals right where they're applied, numbing the area without knocking you out. But then you have the really profound drugs. Neuromuscular blocking drugs, NMBDs, paralytics.
Used the OR, ICU?
Absolutely. Essential for things like surgery or putting someone on a ventilator. They cause temporary paralysis. You've got depolarizing ones like acetylcholine works super fast, wears off fast, and non-depolarizing ones like rocuronium, which block acetylcholine at the muscle junction.
What is the absolute cannot miss safety point when a patient is paralyzed with an NMBD?
This is huge. NMBDs paralyze muscles. They do not provide sedation. They don't relieve pain. They don't stop anxiety. The patient can't move, can't speak, but they might be wide awake and terrified.
So you must ensure they're adequately sedated and have pain relief before paralyzing them.
Non-negotiable. It's a core safety check. Imagine being aware during surgery but unable to move. Horrifying. Concurrent analgesia and sedation are mandatory.
You mentioned a specific NMBD that's good for kidney failure patients.
Ah, yes, cisatracurium. It's got this really neat property. It breaks down through something called Hoffman elimination. It's basically a chemical breakdown in the blood. Depends on pH and temperature, not the liver or kidneys.
So it bypasses the usual elimination routes.
Exactly, which makes it ideal if someone has end-stage renal disease. Pretty elegant chemistry.
And we should quickly mention malignant hyperthermia.
Yes, rare, but potentially deadly. It's an inherited reaction to certain general anesthetics, inhaled gases, and succinylcholine.
What are the signs?
It comes on fast and hard, sky-high heart rate, really rigid muscles, and body temperature shoots up rapidly. Needs immediate recognition, cooling, and specific drug treatment.
Okay, we've used depressants for pain. Now let's talk about using them to calm the CNS for anxiety or sleep. What's the difference between a sedative and a hypnotic?
Good question. A sedative kind of chills you out, reduces nervousness, irritability, but doesn't necessarily make you sleep. A hypnotic is intended to induce sleep.
But sometimes the same drug can do both.
Often, yes. That's why we talk about sedative hypnotics. It's dose-dependent. A lower dose of something like a benzodiazepine might be sedative, while a higher dose acts as a hypnotic.
And these drugs mess with our natural sleep patterns, don't they?
They do. Normal sleep cycles through different stages, including REM sleep, which is important for processing things. Long-term use of many sedative hypnotics causes REM interference. You get less REM sleep.
Which makes you feel groggy.
Yeah, often leads to daytime fatigue, feeling unrested. Then, if you stop the drug suddenly, you get REM rebound.
What's that?
The body tries to catch up. You get way more REM sleep than usual, which often leads to really vivid, sometimes bizarre or disturbing dreams. It's another big reason why you never stop these drugs abruptly. Hashtag tag 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 2.2 benzodiazepines and their counterparts.
Okay, the big players here. Benzodiazepines, diazepam, Valium, lorazepam, Ativan, midazolam, Versed. How do they work on that neurochemical balance?
They're all about GABA, gamma-aminobutyric acid. It's the brain's main inhibitory or calming neurotransmitter. Benzos basically make GABA work better, amplifying its inhibitory effect. They turn down the volume in areas like the brainstem and the limbic system, which handles emotions.
They're used for a lot of different things.
Oh yeah, super versatile. Quick sedation, anxiety relief, muscle relaxation, stopping acute seizures. And critically, they're the go-to treatment for managing acute alcohol withdrawal. They can prevent the really dangerous symptoms.
Oh, wait, there's a massive safety warning attached.
Yeah.
That FDA black box warning.
This cannot be emphasized enough. The FDA put out its strongest warning about using benzodiazepines together with opioids.
Why is that combination so dangerous?
It's not just additive risk, it seems to be exponential. Both drug classes depress the CNS, especially breathing. Put them together, and the risk of profound sedation, stopping breathing, coma, and death goes way, way up. Clinicians really need to avoid this combo unless there's absolutely no other choice, and even then, with extreme caution.
We also have those newer sleeping pills, the non-benzodiazepines like Zolpidem, Ambien. They have their own specific warning, right?
They do. Another black box warning, this one about complex sleep behaviors. Things like sleepwalking, sleep driving, making and eating food, even having conversations, all while not fully awake.
And they don't remember it afterwards.
Often, no memory at all. The risk of injury or accidents is significant. That's why the advice is always, take it right before you get into bed, and only if you can dedicate a full 7 and 8 hours to sleep.
Let's quickly touch on the older drugs, the barbiturates. Why don't we use them much anymore?
Two main reasons. First, their therapeutic index is very low. That means the dose that helps isn't far off from the dose that's toxic or lethal. Overdosing, accidentally or intentionally, is much easier and more dangerous than with benzos.
And the second reason?
This is a big one we see across several CNS drug classes. Barbiturates are powerful enzyme inducers in the liver.
That enzyme induction theme again. What does that mean in practice?
It means they rev up the liver enzymes that break down other drugs. So if you're taking a barbiturate, it can make other medications you're taking get metabolized much faster, making them less effective.
Like oral contraceptives.
Exactly. That's the classic high-stakes example. A woman taking barbiturates or certain other enzyme inducers might find her birth control pills aren't working effectively because they're being broken down too quickly. She needs to use a reliable backup method, like a barrier method, to prevent unintended pregnancy. It's a critical piece of patient education.
Okay, we talked about calming the CNS. Now let's flip it, activating the CNS with stimulants. We're targeting those excitatory pathways now.
Precisely. We're stimulating neurons that use dopamine and norepinephrine mainly. These drugs mimic the fight-or-flight sympathetic nervous system, so we call them sympathomimetic.
And the effects are?
Increased alertness, better focus, elevated mood, decreased appetite. Really useful for conditions like ADHD where focus is a challenge.
So what conditions do we use these for?
ADHD is a big one. Narcolepsy, that condition causing excessive daytime sleepiness. Sometimes for specific types of migraines, and historically, though less common now, as appetite suppressants or anorexians for obesity.
For ADHD and narcolepsy, we often use pretty potent stuff, right? Amphetamines like Adderall, methylphenidate like Ritalin or Concerta.
Yes, those are Schedule II controlled substances. Very effective, but they definitely have a high potential for tolerance, dependence, and abuse. Needs careful management.
Is there a non-stimulant option for ADHD?
There is. Atomoxetine, brand name Strattera. It works differently by blocking the reuptake of norepinephrine. The advantage is it's not a controlled substance, less abuse potential.
But still has risks.
Yes, it carries a warning about increased risk of suicidal thoughts or behaviors in kids and adolescents. So it's not risk-free, it's just a different risk profile. Always a trade-off.
What about for obesity? You mentioned anorexians.
Yeah, stimulants like phentermine can be used short-term along with diet and exercise. But there's also a non-stimulant approach, orlistat.
How does orlistat work?
It's interesting. It works in the gut, not the brain. It's a lipase inhibitor. It blocks enzymes that break down dietary fat, so less fat gets absorbed.
Side effects related to that?
Directly related. Since the fat isn't absorbed, it has to pass through. So common issues are things like oily spotting, gas with the discharge, fatty stools, sometimes fecal urgency or incontinence. Unpleasant, but directly linked to how it works.
Okay. And for migraines, specifically treating an acute attack.
For acute migraines, the go-to drugs are often the triptans, like sumatriptan, Imitrex. These are for abortive therapy. You take them when the migraine starts to stop it.
How do they work?
They're selective serotonin receptor agonists. They seem to work by causing vasoconstriction narrowing of blood vessels in the brain, which helps shut down the migraine process. We also sometimes use analeptics, which are CNS stimulants like caffeine. High doses can stimulate breathing, so it's used sometimes for neonatal apnea or as an add-on in some pain relievers.
Right, let's pivot to stabilizing long-term neurological conditions. Starting with epilepsy and anti-epileptic drugs, or AEDs. Epilepsy is basically the brain being hyperexcitable.
That's a good way to put it. Neurons are firing way too much, too easily. The goal of AEDs is to stabilize those neurons, make them less likely to go haywire. Often they do this by, guess what? Boosting GABA again, enhancing that inhibitory tone.
Now, with AEDs, we often hear about needing to monitor drug levels in the blood. Why is that so important for drugs like phenytoin or phenobarbital?
Again, it comes down to that narrow therapeutic index. The window between a dose that controls seizures and a dose that causes serious side effects or is toxic can be quite small.
So you need blood tests to stay in that sweet spot.
Exactly. You titrate the dose carefully to find the lowest level that works for that specific patient, keeping them seizure-free, but minimizing toxicity. This means regular lab work is essential and a huge nursing point. You never tell a patient to just stop taking their AEDs suddenly.
Why not?
Abrupt withdrawal can trigger rebound seizures, potentially leading to status epilepticus, a continuous seizure state that's a medical emergency. Tapering off, if needed, must be done slowly under medical supervision.
But if status epilepticus does happen, what's the immediate treatment?
Get a benzodiazepine in quickly, 5E diazepam or lorazepam. They work fast to enhance GABA and hopefully break the seizure cycle.
Let's talk about phenytoin, Dilantin. It's a classic AED. What's that well-known long-term side effect, especially with oral use?
Gingival hyperplasia. Overgrowth of the gum tissue. It doesn't happen to everyone, but it's common enough that patients need really meticulous oral hygiene and regular dental visits.
And giving phenytoin intravenously has its own problems.
Oh, yeah. Regular phenytoin for IV is very alkaline, it burns like heck, and can cause serious tissue damage if it infiltrates. That's why they developed phosphonytoin.
Phosphonytoin is a prodrug.
Right. It's inactive itself that gets converted into phenytoin in the body. It's water-soluble, much less irritating to villains, but still needs careful administration.
How so?
You have to give it slowly, usually no faster than 150 milligrams of phenytoin equivalents per minute. And you need cardiac monitoring because rapid infusion can cause severe hypotension or heart rhythm problems. Still needs respect.
And here we go again. Enzyme induction.
It's back. Yes, many AEDs, including phenobarbital and another big one, carbamazepine, Tegretol, are potent enzyme inducers.
So same issue as with barbiturates. Reduced effectiveness of other drugs, especially birth control.
Exactly the same issue. Alternative contraception is a must. Plus, carbamazepine has a specific, very important food interaction.
What's that?
Grapefruit juice. Strictly avoid it. Grapefruit inhibits the enzyme that breaks down carbamazepine, leading to potentially toxic high levels of the drug. Hashtag 4.2 anti-Parkinson drugs.
Okay, shifting to Parkinson's disease now. The core problem here is losing dopamine-producing cells in a part of the brain called the substantia nigra.
That's the pathology, yes. Those dopamine neurons die off. Dopamine is largely inhibitory in this pathway, while acetylcholine is excitatory. Lose the dopamine, and acetylcholine runs rampant unopposed.
And that imbalance causes the classic Parkinson symptoms.
Right. Remembered by the acronym TRAP. T for tremor, often that pill-rolling kind. R for rigidity, stiffness. A for akinesia, which really means lack of movement, but clinically we see it as bradykinesia, profound slowness. And P for postural instability, balance problems later on.
So the goal of drug therapy isn't to cure, sadly, but to rebalance things.
Exactly. We can't stop the neurons from dying yet. Therapy aims to either boost dopamine levels or block that excessive acetylcholine activity, or both, just to manage the symptoms.
The cornerstone drug is carbidopa-levodopa, right? Sentiment.
Gold standard for dopamine replacement. Levodopa is the precursor molecule that the brain can turn into dopamine.
Why add the carbidopa? Why not just give levodopa?
If you just gave levodopa, most of it would get broken down in the bloodstream by an enzyme before it even reached the brain. Carbidopa is an inhibitor of that enzyme. It basically acts as a bodyguard, allowing more levodopa to get across the blood-brain barrier where it's needed.
Makes sense. But even with this combination, patients can run into problems over time. These phenomena.
Yes, long-term use brings challenges. There's the wearing off phenomenon, where the drug's effects start to fade before the next dose is due. Patients feel their symptoms returning.
And the on-off phenomenon.
That one's even tougher. Patients can swing unpredictably between periods of good mobility on time, though maybe with some dyskinesias, extra movements, and periods of severe stiffness and inability to move off time. These swings can happen rapidly and be really disabling.
Managing that must be incredibly difficult.
It really is. Requires careful dose adjustments, maybe adding other drugs. And there's a crucial diet consideration, too.
Ah, yes, the protein interaction. Tell us about that.
High-protein meals can significantly interfere with levodopa absorption and its transport into the brain. Levodopa actually competes with amino acids, the breakdown products of protein for the transport systems that carry things across the gut wall and the blood-brain barrier.
So timing the drug around protein is key.
Absolutely critical. Patients are usually advised to take their carbidopa-levodopa about 30 minutes before eating protein, or at least an hour after. Some people find it helps to save most of their protein intake for the evening meal, away from their main daytime doses. Consistent timing is vital.
And we also use anticholinergic drugs like benzodiazepine, cognition.
Yes, as adjuncts. They directly target that overactive acetylcholine system. They don't help the bradykinesia much, but they can be quite good at reducing the tremor and rigidity.
Okay, final big section, psychotherapeutics. Drugs for mental health conditions, we're talking mood disorders like depression, bipolar. What's the underlying chemical idea here?
The classic theory is the biogenic amine hypothesis. Basically, it proposed that depression is caused by a deficiency of key neurotransmitters, norepinephrine, dopamine, serotonin, while mania is caused by an excess.
Kind of like a chemical imbalance.
Sort of. It's been refined over time. There's also the permissive hypothesis, which suggests maybe low serotonin is the underlying issue, creating a permissive state. Then, whether norepinephrine and dopamine are high or low determines if you get mania or depression on top of that low serotonin foundation.
So antidepressants are generally trying to boost these neurotransmitters.
That's the main goal, yes. Increase the levels of norepinephrine, serotonin, or dopamine in the synapse. But, and this is crucial, patient education, it takes time.
How long?
Patients absolutely need to know that they might not feel the full benefit, the mood lifting, for a good 4 to 6 weeks after starting the medication. It's not like taking an aspirin for a headache. That delay is a major reason people stop taking them too soon. So managing expectations and providing support is key.
Yeah.
Hashtag tag 5.2, antidepressants and mood stabilizers.
The first-line drugs these days are often the newer ones, SSRIs and SNRIs.
Right. Selective serotonin reuptake inhibitors like fluoxetine, Prozac, or citalopram, Celexa, and serotonin norepinephrine reuptake inhibitors like venlafaxine, Effexor, or duloxetine, Cymbalta. They generally have fewer side effects than the older tricyclics or MAOIs, which is why they're preferred now.
How do they work? SSRIs specifically.
They block the reuptake pump on the sending neuron that normally sucks serotonin back up after it's been released. By blocking that pump, more serotonin stays in the synaptic gap available to stimulate the receiving neuron. SNRIs do the same for both serotonin and norepinephrine.
But if you boost serotonin too much or combine drugs that boost it, big trouble.
Huge trouble. That's serotonin syndrome. It's a potentially life-threatening emergency caused by excessive serotonin activity.
What causes it?
Often, polypharmacy combining an SSRI with an older MAOI is a classic no-no, but it can also happen with combining SSRIs with triptans for migraines, certain opioids, even the herbal supplement St. John's wort.
What does serotonin syndrome look like?
It's a constellation of symptoms. Mental status changes like delirium, agitation, autonomic instability, racing heart, high blood pressure, high temperature, sweating, and neuromuscular problems, muscle rigidity, myoclonus jerking, hyperreflexia, tremor, needs immediate recognition and stopping the offending drugs.
Okay, for bipolar disorder, we often use mood stabilizers, sometimes AEDs.
Yes, drugs like valproic acid or lamotrigine, which we use for seizures, are often first-line treatments for bipolar disorder now. But the classic mood stabilizer, the old standby, is lithium.
And lithium is famous for its tricky dosing.
Infamous, maybe. It has an incredibly narrow therapeutic range. We aim for blood levels between about 0.6 and 1.2 MEQL. Too low, it doesn't work. Too high, it quickly becomes toxic, requires very close monitoring, especially early on.
And there's a critical interaction with sodium.
Yes, this is vital for patients to understand. The kidneys handle lithium very similarly to how they handle sodium. If a patient becomes low on sodium, maybe they're sweating a lot, have diarrhea, or go on a crash low-salt diet, the kidneys try to conserve sodium.
And they hold on to lithium too.
Exactly. They mistake lithium for sodium and reabsorb more of it, causing lithium levels in the blood to shoot up into the toxic range very quickly. Patients on lithium need to maintain a consistent normal salt intake and adequate fluid intake. No sudden changes.
Got it. Finally, antipsychotics for conditions like schizophrenia. We mostly use the atypicals now.
Mostly, yes. Drugs like risperidone, Risperdal, olanzapine, Zyprexa, quetiapine, Seroquel, they're generally better at treating the negative symptoms of schizophrenia like withdrawal, apathy, compared to the older conventional antipsychotics. And crucially, they tend to have a lower risk of causing certain movement side effects.
But atypicals have their own issues, like metabolic problems.
That's their main drawback for many. Significant weight gain, increased risk of diabetes, high cholesterol, requires careful monitoring of weight, blood sugar, lipids.
But the side effects we really worry about, especially with the older drugs, are those movement disorders caused by blocking dopamine.
Right. Those are the extrapyramidal symptoms, or EPS. Because these drugs block dopamine receptors, they can create a state that looks a lot like Parkinson's disease, stiffness, tremor, shuffling gait. That's pseudoparkinsonism. Also, akathisia, this awful inner restlessness, inability to sit still. And acute dystonia's painful muscle spasms, often in the neck or eyes.
And the long-term, potentially irreversible one.
That's the most feared one, tardive dyskinesia, or TD.
What does TD look like?
It typically involves involuntary, repetitive movements, usually of the face, tongue, and lips, things like lip smacking, tongue protruding, grimacing, chewing motions. Sometimes affects the limbs or trunk too. The devastating part is that it can persist even after the drug is stopped and may be irreversible.
Which really emphasizes using the lowest effective dose for the shortest time possible.
Absolutely, and constantly screening for early signs. It's a major reason the atypicals, despite their metabolic risks, are often preferred. The risk of TD seems to be lower, though not zero.
Okay, our last section really brings all these CNS drugs together, looking at substance use disorder. This is where manipulating that balance goes wrong, and prescription drugs are a huge part of this problem now.
A massive part. We're not just talking street drugs. The misuse of prescription opioids, stimulants, benzodiazepines, it's a major public health crisis.
Let's focus on opioid abuse first. You mentioned dangerous combinations earlier.
Yeah, that so-called holy trinity on the street, combining an opioid, a benzodiazepine, and the muscle relaxant carisoprodol, soma, each one depresses the CNS. Together, the risk of fatal overdose is incredibly high.
When someone is withdrawing from opioids, what does that look like? It's like the nervous system goes into overdrive.
Exactly. The depressant effect is gone, so the sympathetic nervous system just rebounds violently. Intense drug craving, obviously. Physically, you see dilated pupils, mydriasis, sweating, goosebumps, piloerection, nausea, vomiting, diarrhea, muscle aches, high blood pressure, fast heart rate. It's miserable, though usually not life-threatening like alcohol withdrawal can be.
Naloxone is for overdose rescue. How do we manage the withdrawal symptoms?
We can use medications like clonidine, which helps calm down that sympathetic overactivity. For long-term treatment to reduce cravings and prevent relapse, we use things like methadone, a long-acting opioid agonist, or naltrexone, an opioid antagonist.
What about abusive depressants like benzodiazepines or barbiturates? Overdose management.
Overdose basically looks like an extreme version of the therapeutic effects. Profound drowsiness, maybe coma, slurred speech, poor coordination, and again, the big danger is respiratory depression.
Is there a reversal agent for benzos like naloxone is for opioids?
There is, yes, flumazenil. It specifically antagonizes benzodiazepines at their receptor site. It's not used as routinely as naloxone, partly because benzo overdose alone is less often fatal than opioid overdose if breathing is supported, and partly because rapid reversal with flumazenil can sometimes trigger seizures in people who are dependent on benzos.
Okay, let's talk about ethanol alcohol. Profound long-term risks here.
Huge risks. Irreversible damage to the heart muscle, cardiomyopathy, liver, cirrhosis, brain, and we absolutely have to mention the risk during pregnancy.
Fetal alcohol syndrome.
Yes, a devastating consequence. Alcohol is a teratogen. It interferes with fetal development. There's no known safe amount of alcohol during pregnancy. Complete abstinence is the only safe course.
Alcohol withdrawal. This one can be life-threatening.
It absolutely can. Unlike opioid withdrawal, it can progress to delirium tremens or DTs. This is a medical emergency. Severe agitation, confusion, hallucinations, fever, racing heart, dangerously high blood pressure, seizures.
How do we treat alcohol withdrawal safely?
Benzodiazepines are the treatment of choice. Because there's cross-tolerance between alcohol and benzos, they both work on GABA, benzos can substitute for the alcohol, calming the CNS and preventing seizures and DTs. Usually requires symptom-triggered dosing in a hospital setting.
And there's a drug to help people stay off alcohol.
Disulfiram and abuse. It's aversion therapy. It works by messing up how the body metabolizes alcohol.
How so?
Normally, alcohol breaks down into acetaldehyde, then into harmless acetic acid. Disulfiram blocks that second step. So if you drink alcohol while taking it, toxic acetaldehyde builds up rapidly. Acetaldehyde syndrome. Intense flushing, pounding headache, nausea, violent vomiting, sweating, weakness, low blood pressure. It feels absolutely dreadful. It's powerful negative reinforcement, but the patient has to be motivated to take it consistently.
Lastly, nicotine. Highly addictive. What helps people quit?
Very addictive. Aside from nicotine replacement therapy, patches, gum, there are medications. Apropion, which is also an antidepressant, marketed as Zybin for smoking cessation, and varenicline, Chantix.
How does varenicline work? It's kind of clever.
It is. It's a partial agonist at nicotine receptors, so it gives a little bit of nicotine effect to ease withdrawal cravings, but it also blocks actual nicotine from cigarettes from binding fully to those receptors, so smoking becomes less pleasurable, less rewarding.
Wow. Okay, we've covered a huge amount of ground, manipulating the CNS from every angle. If we boil this entire unit down, synthesize it, what's the single biggest unifying safety concern across almost all these drugs?
Without a doubt, it's the risk related to CNS depression and injury, whether it's opioids causing respiratory arrest, sedatives causing falls, antipsychotics causing movement disorders that increase fall risk. The potential for depressed level of consciousness, impaired breathing, and physical injury is the common thread. Safety is paramount.
So knowing that, what are the absolute must-do baseline assessments for any patient starting or taking these CNS drugs? Pain, focus, mood, doesn't matter. What do you always check?
Okay, non-negotiables. 1. Complete vitals, especially checking for orthostatic hypotension, measuring blood pressure and pulse lying, sitting, and standing because so many of these drugs cause dizziness on standing up, leading to falls.
Okay, vitals and orthostatics. What else?
2. Baseline liver function tests, LFTs, and renal function tests like BUN and creatinine. So many of these drugs are metabolized by the liver or excreted by the kidneys. You need to know if those organs are working properly before you start, especially with drugs like lithium or certain AEDs.
Makes sense. Number 3.
3. A thorough mental status exam, level of consciousness, orientation, mood, affect, and specifically screening for suicidal thoughts. This is crucial when starting antidepressants, but really important across the board, as mental status changes can be an early sign of toxicity or adverse effects.
And finally,
A complete medication history, including over-the-counters, herbals, and, critically, a non-judgmental substance use history. The potential for interactions and the risks in patients with existing substance use disorders are just too high to ignore.
okay, let's summarize the absolute key patient education points that echo throughout this entire unit. What must patients know?
Okay, top themes. 1. Never, ever stop CNS depressants, like benzos, barbiturates, opioids, or anti-epileptic drugs abruptly. Risk of dangerous withdrawal or rebound seizures is too high. Always taper.
Got it. No sudden stops. 2.
2. The enzyme induction issue. If you're taking drugs like barbiturates, phenytoin, carbamazepine, you need a reliable, non-hormonal form of birth control. The pills might not work. Critical point.
Alternative birth control. 3.
3. Report specific warning signs immediately. New muscle twitching or spasms could be EPS. Any kind of rash could be a severe reaction, especially with some AEDs like lamotrigine. Worsening depression or suicidal thoughts. Confusion, don't wait.
Okay. And 4.
4. Lifestyle matters. Managing constipation, which is common with opioids and anticholinergics. Implementing fall prevention strategies if dizzy or unsteady, common with antihypertensives, anti-Parkinson drugs, sedatives. And that crucial dietary timing with carbidopa-levodopa and protein. Practical stuff makes a big difference.
This has been an incredible deep dive. It really highlights just how complex and, frankly, delicate the process of chemically intervening in the nervous system is.
It really is. We're targeting these fundamental systems, GABA, dopamine, serotonin, norepinephrine, that regulate everything from movement to mood. The overarching goal is always restoring balance, but the primary risk, so often, is tipping too far into CNS depression. Constant vigilance is just the core requirement of care with these medications.
And it raises fascinating questions, doesn't it? When we use these drugs to change mood or enhance focus or control behavior, how much are we treating the illness versus altering the person? Where did the disorder end and the individual's core self begin, especially when the treatment targets the very chemistry of thought and feeling, something profound to think about?
Absolutely, a profound challenge inherent in psychopharmacology.
Well, thank you so much for walking us through this incredibly dense and important unit. That was fantastic.
My pleasure. Thanks for having me.